All right, so this afternoon we're going to jump right into our next panel. It'll be the same after, right? We'll do the WIBGEs and the challenges related to this topic. I'm just trying to give people another second to come in. And all right, I think we're ready to go. So without further ado, Connie Yowell and friends.
Great. Thank you.
And here's this.
Is everybody back? Welcome back. We ready to go? We are your post-lunch conversation. Everybody enjoy lunch? Excellent. So I am Connie Yowell. I am your moderator for this conversation. I am here at Northeastern. I'm a senior advisor to the provost here on special topics, and most of my topics are in education because that's my background. We're working particularly on thinking about the future of higher ed with AI as part of what we're talking about inside the university. I am not a health person, but fortunately, this panel is going to talk about education. So the purpose of this panel really is for us, we've heard such brilliant conversation so far today. Susan with a true vision for public health and technology and where we need to go with the field. And the pressing question in many ways, particularly for those of us in education, is what are the implications for this, for how we think about how we're preparing both our future and our current workers in public health and public health innovation and technology. So the purpose of this panel really is to roll up our sleeves and begin to think about that. And I'm joined by three esteemed panelists here. And forgive me, panelists, I'm going to be super brief on the intros because I think the conversation is so incredibly important. I want to dive right in. We are very privileged to have Rochelle Walensky here, former head of the CDC from 2021 to 2023. Former head of infectious disease at Mass General, and now a fellow at the Harvard Law and Business Schools and the Kennedy School, and they're very lucky to have you. Laura Mahenya, thank you very much. I'm so proud of myself. Thank you for, and I have to read your title, is the President and CEO of the Association of Schools and Programs of Public Health. Thank you so much for being here. We deeply appreciate it. John Brownstein, you're the professor at Harvard Med, and then more importantly for this conversation, you're Chief Innovation Officer at Boston Children's. Thank you so much for being here. Rochelle, I'd really like to start with you in terms of this conversation, and you have seen so much and been across the country so many times in the field of public health, and I'd really appreciate it if you could lay the context for us as we think about the future of education of public health workers, the context that they're going into, and if you could also help us think about timeline and whether or not we need to have a sense of urgency as we think about what is the changes that we want to think about for the future of public health.
Great, thank you. I'm delighted to be here with you. Thank you for the invitation. And Connie, I'm going to actually go back to your opening remarks and say, I think we actually, after the last 4 years, need to consider everyone part of health and public health, regardless of where you are, because we see that it touches every single discipline. And if there's one thing I learned over the last 3-4 years is that it really does touch every single discipline. You know, when I think about where things were when I started at CDC, one of my favorite quotes is, can we send you our COVID test results on our sickle cell fax machine? That is where we were. Yes. So CDC was getting data by fax, by Excel, by cloud, by word of mouth, by email. That was our data system. When the pandemic started, about 187 health facilities were sending in data electronically. I think today we're up to 36,000. Massive progress. And yet, that's about 25% of our healthcare facilities, and that's just case reporting. So when you think about where we need to go first of all, if this were Coca-Cola, it would be a barcode, but it's public health, and it is moving extraordinarily slowly. So I do think we started, prior to the pandemic, there was work happening in data modernization across the agency. The vision, of course, would be that we have healthcare talking to public health in a HIPAA-compliant, privacy-protected way. I'll give you an example of how this was limiting for me. People want to know how their vaccines were working. I very much wanted to know how their vaccines were working. If your vaccine data is in public health and your clinical data, your hospitalization data, your mortality and ICU data are in healthcare, if they don't talk to each other, you can't get a sense as to how your vaccines are working, which is why we went to other countries to get those data faster. And so really it is deeply limiting what we can tell you and the speed at which we can tell you things. So the data modernization effort really got jump-started through COVID dollars. But I do also want to give you a sense, and I feel the urgency, I deeply feel this urgency. People are talking about AI, and AI is sort of the next step, and we haven't caught up to 2024. But $1 billion Congress, about $1 billion Congress has devoted towards our data modernization effort in this country. There are single county health departments who need that budget, one county. And if you look at my former home, Mass General, the Mass General Brigham, the partner system received $1.2 billion or needed $1.2 million to upgrade to Epic. So we have one healthcare system in one state that needed more than the entire federal budget for data modernization. So yes, we've made a lot of progress. We have a lot of places to go. One other piece I just want to say on the education side, there are so many places where education is critically important, but the other piece that I want to say in addition to the infrastructure, the data modernization infrastructure in the country, is in communications. To give you a sense, I started at an incredible agency on January 20th of 2021, and I was told we are doing 3 times a week press conferences, White House press conferences, starting the next day. Great. I said, can I meet my communications director? The position had been empty for 4 years. So I had 4 acting communications directors before 2 years later we were able to hire a full-time communications director. CDC has always been quite good at, foodborne outbreaks, don't eat the lettuce, don't eat the deli meat, whatever it may be. But when you have something of the size, scale, and scope of what we had, you really need public health communications. And what has been critically important we've learned is that is actually IT, that is information technology, that is how platforms travel, word travels, that is vaccine confidence, it is social media, and our benches are really thin on that in public health.
That's super helpful. Can we go a little bit deeper on community now? When we spoke on the phone, you talked about there are some really big challenges for our future folks going out to work in these communities. Some of the innovations may turn out to be bright, shiny objects in some ways. And so how do we think about how we're preparing folks, both our future innovators as well as the workers who are going out into the field to be working in the communities?
Well, I think that's a really great question because it's really one thing for me to sit in Atlanta or for others to sit in their sort of academic homes or to say, like, we need to do this out in the community. And what you really need is for community to be ready to receive it, ready to be implement it on the ground. And that it may very well vary from community to community as to what they need. They may well not have the training to implement that which you are providing or suggesting. I was in Dalton, Georgia, early in the pandemic. That is Marjorie Taylor Greene's district in Northwest Georgia. I paid that district a visit, and we talked about how you might get the community vaccinated. 2 things I learned that was like really important. One is they were willing, actually. They had people who were willing. What you had to do is do a change of shift at the carpet factories at 4 in the morning. You got people who were willing and wanting to be vaccinated. It's just it was kind of taboo in the community. So if you could do it someplace that seemed kind of private, that people wouldn't be ostracized for having done it immediately, then they could go home and say to their partners, I got vaccinated, it wasn't so bad, I'm still here, and now I'm protected, maybe you should get vaccinated too. That was one. The second was, how do you get to Hispanic-speaking elderly. This was before the vaccine was for kids, and the answer was target TikTok to teenage Hispanic teens. Why? Because there's both a digital and a language divide. And so, like, you really do need to go into the communities to understand what it is that they need, how technology could reach them, and how they could use it for the best possible way.
That's really helpful. I want to just shift gears just for a second while we've got you here. You have served our country with such grace and dignity in leadership positions across the board. We hope that many in this room will be preparing our future leaders. Can you say just a little bit about that experience and advice on what our future leaders are going to be facing and the skills and competencies they're going to need?
Well, first of all, as I look in the room and see so many friendly faces who were there with me or who are there now and actively continuing in those roles, I do want to say thank you to them. CDC is a massive organization, and it is very hard to touch everybody. And it's also hard when you say, well, does CDC like that? It's like, well, it's like a city. Like, did that city like it? No, I'm sure that there are some places that were unhappy with certain policies. What I will say is, for me personally, like, there had to be resiliency. There had to be like, okay, that was a terrible story on the top of the New York Times, and I'm gonna like look at it, know that it was there, read it, know what it said, and then put it in a box and kind of shelve it, because there's like bigger fish to fry today. That will wrap today's fish tomorrow, and that'll be fine, right? So there is like this component of you have to protect that. Second is empathy. I mean, the folks, when I started at CDC, I had learned that the security officers, the security team at the agency had asked people to take off their their parking stickers from their cars for fear of vandalism. That was the morale of the agency that I inherited. And so, you know, you really do, there was some tough love, because there were mistakes made. We needed to acknowledge those mistakes if we were going to regain public trust. And you had to remember the love part of that. So you really did have to say, we have to push harder, we have to give more, we have to be stronger, and I value what you're doing. So how do you demonstrate the I value what you're doing? I did a lot of one-on-one meetings. A page out of Juliette Kayyem's book, The Devil Never Sleeps, is never pass out your business cards in an emergency. And so I really tried hard to meet people before there was an emergency. I remember early in my tenure, there was a civil unrest in Haiti, and my security team had called and said, we're not sure our team in Haiti is okay. That was the first time I'd called our team in Haiti. That is not how you want to say hello. So then I made it my business to call every country director across the country, across the world. We have 60 offices in 60 different countries. I called every single one of them just to meet them, so that if there was another challenge, my first phone call wouldn't be, are you alive? Is your team okay? We have an office in Ukraine. So I was very grateful when there was invasion of Ukraine and our office had to evacuate, that I had already had a conversation with, and that's just one of many examples. So there is this sort of like, I'm here for you, I'm true to my word, I've got your back, and I will do my best to defend what you need, and I see you. I want you to feel valued.
It's terrific, and thank you for laying that context. Laura, with that as context, I want to transition into really thinking about what are the implications for how we're going to think about transforming public health education. And I know I've got a long background at innovation, and we always, in framing it, need to have a framework that allows us to think about where we're coming from and where we're going to. And I know you've got a deck to really guide us in that conversation. Thank you.
Thank you so much. And first of all, thank you for having me. I'm delighted to be here, very excited to talk about the current and the new field that all of you are really pushing hard to really develop in academia, which is the public health technology. Thank you for leaders that have preceded me during this day's conversation. And yes, I'm contributing right now a little bit differently, which is more, now what do we do? How do we train all these people that we all need? This morning we were talking about how to use technology and the digital skills in the current and the future for the benefit of all our communities. So, but what happens with higher education, right? And just to add a little bit of facts, it's like We all know that 90% in the next 10 years, 90% of the jobs will require technology and digital skills. We already know that 50% of the jobs in the next 10 years will disappear or completely change the way they are today, right? We already know that. So we're training our students. I want you to think that we're training our students right now for jobs that doesn't exist right now. So what do we do, right? What are the things that we need to be training them if we don't even know what they're going to be doing in the future? And moreover, also, these students, it's proof that for in the next generation, they're going to be changing their careers 12 times. And they're going to stay in the workforce until their middle or late 70s. So that's the panorama in terms of the workforce. So then, what are the things that we really need to be changing in higher education, and in particular this incredible opportunity to create a completely new field, which is public health technology? And that's why I put together, just because it's easier to just visualize, I'm going to be talking a little bit about what are those blocks, really the building blocks, I call them, in order to, if we start really talking about a completely new field. Number one, we need to go to think beyond disciplines collaboration. And this topic, since the morning, all of you have been talking about, academia is very silo-oriented. Everybody works in their own silos, even the health professions. We are, the nurses, the public health people, the physicians. That cannot continue anymore because the problems in the real world are multidisciplinary, are transdisciplinary. It's not a one person or a one field problem. We all need to be together to solving the problem. So if that's the work, we need to train the people to work together, transdisciplinary. Number two, we have been focused on a very telescopic vision of education, meaning that we think, because remember, higher education comes from many years ago, many decades ago, 100 years ago, maybe we'll be fine to all meeting the same criteria, entry criteria, and then exit criteria. That's not reality anymore. Everyone comes from very different backgrounds, different ages, different needs. We need to go from a telescopic kind of view to a kaleidoscopic. We need to think about what are the unique experiences that each of our learners would need for this technological and changing environment that we have in a single day. Number three, we need to go from content to competencies. We use, again, higher education used to if we think right now about the new field, I'm sure in the schools are going to start what's the content, right? So we shouldn't start there. That's wrong. We need to start with what are the competencies that this new field, that this new people are going to have in order to work in the environment. What are the competencies they need? Once we develop the competencies, then of course, what is the content? What are the courses that they need to take? But we need to start with the competencies. So when we talk about competencies, that's also another important thing. Sometimes we're very good at going to the third one, right? The technical and specialized. And I'm sure since this morning we already have the list of data. They need to be very good at predicting scenarios and data governance. And we came up with all the list, right? Which is fine, but that's number three. Really, the 1 and 2 are as important because it's not just the data. And you were saying this in a while. It's not just the data, but how do you use the data? How do you communicate that data? How do you take that data for decision making? So that's more in the social, emotional, or in the metacognitive skills. So our curriculum, if we're thinking right now about, yes, it's exciting to have a new program, which is going to be the public health technology. Well, I really envision that new field is going to have these three equally important because we need people that works with the machine, that interact with the technology, and that's human. Social and emotional is extremely important. It's about empathy. We're talking about health equity this morning, right? It's about resilience. It's about communication. It's about being part of the team, right? So yes, having all the knowledge and expertise is very important, but it's extremely important that I can communicate everything that we're doing. And of course, the cognitive, which is more the self-reflecting in terms of what do I need, how do I keep myself informed and educated during the rest of my life, and the critical thinking, all of that is in the cognitive. Number 4, I think that we need to stop kind of, in education, we're like, what's better? No, all the students have to come back to the campuses. No, let's leave everyone online. So we're still having these debates about online versus in person. I think that we have already learned that all these models, and even more, all of them are effective. So we need to just embrace them, that we're so lucky in these times that we do have technology, that we have the online, that we have the in-person, that I would say, or I will argue that it depends on the competency. There are some competencies that are great. The social competencies that we were talking, of course, that's more like an in-person competency. But if I have competencies that are more like in the knowledge, in the technical, the students can study those online with no problems. At the end, the most important thing, no matter if it's online or if it's in person, it's really the focus of education. It has to be student-centered. So we already know those things. So I don't know why in higher education we spend so much time really discussing and not acting. So I'm really hoping that this new profession, where it is based in case studies, in project-based learning, experiential learning, teamwork, everything related to engaging the adults or our learners in the process. If we talk about competency-based education, we should not care about the time. It's interesting because our education and actually our accreditors said like, okay, in order to do your master's degree, you have to have these grades, which is 8 months in a classroom, right? Meaning that you're really measured by the time you're sitting in a desk or in a chair, as opposed to mastering the competency. If you really have an honest competency-based education, what you evaluate is the mastery of education, of the competency. If you take a month, 3 months, or a year, it doesn't matter. So it should be just, the question should be really the opposite. So the time should be depending on, it's just variable, and really the competency needs to be the one who are we really evaluating. And of course, and I know that here in Northeastern and some of our other schools are already thinking that it's not just about degrees. Degrees are important, are going to continue to be very important, but if we think about the workforce, and she was talking about the importance of maintaining them educated, then we need to think about all the other alternatives. They are not going to come back for another 3 more years or 4 more years, so we need to be thinking about micro-credentials, short online courses, like on-the-job courses. Remember, lifelong learning, and I know that you're going to be talking about that, it's more about engaging the students in this journey of education. I'm going to, just 2 more. This one, the new roles for faculty, is extremely important too, because if we think about competency-based education, if we think about time variable, if we think about all these things, well, faculty has to change. We don't need lectures anymore. We need people really who design scenarios for learning. We need coaching. We need mentors. We need people that can really follow the trajectories of the learners for life, right? And ending with this one that somebody also this morning was talking about, partnerships. Let's just stop the silos. This is not an academia versus the practice side of the governmental public health. No, it's all of us. We need to be together in order to really create a new field, and that's very exciting. And thank you so much for really amazing leaders that we have right here on the room that have really taught us the importance and are pushing us in really developing the new field of public health technology, which I'm so excited about it, but it really required all of us to work intensively in this and to keep on doing it, but let's just do it with the things that we already know that works for education.
That's great. Thank you, Laura. You've really given us a compass for next steps. I appreciate that. John, I want to pull a through line between both what Rochelle has said and what Laura has said, and really talk about it in the context of innovation. We've got to be preparing our next folks and our next leaders as innovators in public health as well, and we learned earlier today that those 2 things rarely date, if ever, become a thing. So tell us, let's first start with, how do you do public health innovation, particularly in a way that touches the community and the way that Rochelle was describing?
Thanks. Can you hear me? Yeah. Thanks so much, and it's great to be here. I see actually a lot of amazing colleagues and public health luminaries who have really figured out the ways in which to innovate in public health. that hasn't really been a thread that we have focused on enough. When I was doing my public health education, the idea of technology was, maybe, doing something in a stats program, but beyond that, there was really no effort to think about either entrepreneurship or technology or partnership, and I'm glad you mentioned partnerships because, it's amazing that the resources that are going into the data monetization efforts at CDC, but of course that's not enough. If we think about what we're trying to do at the community level, and I think Rochelle, you made a great point of meeting people where they are, using the technologies that they're using, these are heavily funded companies and efforts that we don't effectively tap into. So I get to run an innovation program at Boston Children's, and the amount of investment in IT and partnerships and on the commercial side is substantial, and I get to benefit from a lot of that effort and see like the integrations that we can bring in. Then I look to my public health efforts, I see none of that. I see no partnerships, I see no investment, I see no startup spirit. We'll have a session next which highlights some really amazing efforts, but overall, there's like 100 to 1 when you look at a digital health startup versus a public health startup. So we have to figure out how to partner effectively, and we need to meet people where they are. So why not go to the companies like TikTok and engage with them to help them build out a public health vertical? Facebook, during the pandemic, created a survey tool that was the largest public health survey ever created, and they could survey across the globe for outcomes and vaccination status. That program ended, unfortunately. That could have been incredibly valuable now with H5N1. It could be valuable for a range of public health efforts. So it's not about these companies working in a silo. It's figuring out ways for us to keep engaging with them to make them recognize the value of these tools that they're bringing. Because what's happened since COVID is we see a graveyard of technologies. The effective technologies are ones that we've seen some partnerships. My colleague Sam Scarpino here, we launched a program called Global.Health. That was funded by Google. That was using Google resources, Google Cloud, AI tools, and that to this day is still operating and now is effectively doing surveillance for H5N1. So that's an effective partnership between industry and academia. Another example is vaccination access. So we know how hard it is just to get someone to walk a couple blocks to get a vaccine. Lo and behold, transportation is an issue for many people, for many communities. We study these things, we understand social determinants, a wide range of factors, but transportation is an issue. So we went to Uber and we said, well, what if you consider doing on-demand vaccination to get people vaccines, meet them where they are? And somehow we convinced them, and now that's a whole effort within Uber called Uber Health that continues this day to effectively support patients to get to appointments, get home, does prescription delivery. So you can do this. It takes a lot of work, but these companies do want to unlock their efforts, their social responsibility. There's also a business model at hand as well, so it's not completely philanthropic either. So there is real opportunity. And now as we talk about AI, the partnerships that exist, they're so much insight. We're in partnership in the hospital with OpenAI right now. We've democratized access to ChatGPT. Every person in our institution can access ChatGPT. We understand this is going to change the nature of work. We're not seeing that necessarily, that same level of investment on the public health side. I know there's incredible work happening at CDC in adopting AI, but somehow public health is still a few steps behind even the rest of the medical field.
How do we then start preparing people to be more like you and to begin to build those kinds of innovations?
Well, it's not about turning every public health practitioner into an engineer or data scientist. I mean, of course, you need to have data literacy and proficiency and understanding how to interpret data, how to communicate data. I mean, that, of course, is key, but it's also the capability of interfacing with engineers. I mean, Northeastern does this as well as any place because they have figured out how to create programs in medical informatics that combine with public health. Often these informatics efforts are completely separate from public health efforts. And we're seeing that even within our own institution. There's incredible public health work that could actually inform public healthcare practice. We saw some of that happen during COVID and some of the capacity planning and prediction and forecasting. We finally saw public health models coming into healthcare. There's still a significant amount of siloing. So I think to the point that we heard from Laura, which was really thinking about the interdisciplinary efforts, the hands-on experiences in public health education that gets people into these environments. And we host a lot of Northeastern students that get to have that experience in public health surveillance, but it's not nearly enough availability of these kind of opportunities for public health students right now.
Go ahead, Laura.
Can I add? We need to start in K-12. Really. I mean, we need to start very early in education with the things that now we value the most, right? So innovation, technology, resilience, all of these competencies that right now is just like we must have, this new generation with all these. Well, let's start in kindergarten, because that's where you really start developing all these important. So I can see innovation as being one of those competencies that they need to start early.
Yeah, and that's to Rochelle's point that everyone is involved in health. It's not siloed. I'm going to ask John one more question, and then we are going to have time for Q&A, so I'm going to open it up to everybody else because I know you're dying to ask questions. John, I'm going to give you the magic wand to close us out just in this part of the discussion. In innovation, we are always, in education in particular, we're always asked this question of, are we going to incrementally innovate or are we going to start anew?
Right.
So we've got to think about, pull on the thread of what Laura presented in the radical transformation. How do we want to think about what we're going to do with public health and technology?
Right. I mean, obviously, it's the key partnerships. I mean, we're seeing actually innovative public health efforts happening on the education front right now. University of Arizona just launched a School of Public Health and Technology. I mean, that's the first in the country, and that's incredible to see someone from there to here. Oh, Arizona State. Sorry. I'm Canadian. It sort of gets confused for me. Sorry. That's amazing. So, I mean, that is an example of what can happen when we think much more forward about the opportunities. But I think there's something different that we need to think about in terms of public health education, and it hits on something you mentioned, which is we can't be sort of static in public health education. You have a 2-year degree, and then you're out the door. In the medical practice, you have to do CMEs. You're a lifelong learner. There is proficiencies that need to be constantly tuned, and we don't do that in public health. Yet somehow technology is moving at a rapid pace. AI is going to change the nature of work. The job of a public health practitioner is today will not be the same in 4 years. So why are we creating this time bound of education? And in fact, AI will become the dominant player in how to facilitate that lifelong learning, because you can have tools that are customized, that are personalized to your own needs, that allow you to have on-demand curated content. So I think the technology will influence the job, but the technology will also influence how we stay current with how to actually do the job as well.
Go ahead.
I just want to add, I completely agree with everything that's been said, and also there is this perception that public health is government responsibility, that it is local and federal government responsibility. And let me tell you, if we leave it to the government, God bless the government, but it's going to move too slowly. And I already see that I'm torn between this leapfrog or not, because if we try and go through, we are, our data modernization efforts are already way behind. We're using AI before we have done our highways don't even connect, for goodness sake. So if we rely on the government to sort of move this alone, then it will move way too slowly, and the capacity to do all of the things that we really expect and need it to do will not be there.
With that as the urgency of the moment, I want to turn it over to folks in the audience for questions. To really, we've got a few minutes if folks want to dive in and ask some questions and start us going. That way would be terrific. Related, future of education. Go ahead, thanks.
Thank you so much for this great panel. I've learned so much, and I think I have a Master's of Public Health, and I really appreciated that program, and I'm also a Northeastern alumni, so I have to shout that out. But I wanted to go back to kind of what you were talking about, John, and the business model of public health innovation, because I run a health tech accelerator for digital health solutions, and when I think about what's the accelerator model for public health solutions, I don't know who those investors are, and I wonder if you could expand on kind of your thinking around that.
The pool of money for public health, it's just a lack of understanding, and I think we need to do a better job as a public health community to first fund entrepreneurship, so to create sort of the new next idea, because in fact in public health programs we're not encouraging people to think out of the box or create a new idea and a new venture. So there's just not that sort of cohort of people that are thinking. I mean, we'll hear from BioBot later. That's a great example of a public health company startup that's gotten real investment, and they got investment from sources that are not public health specific, like these are generalist funds. These funds will be interested in topics that have real impact. Obviously, you need to have a customer for the things that you're doing, and they've found customers in government and in industry. And so there are plenty of examples of good startups and entrepreneurs that have been very successful in public health. But again, we just don't have that pool. I think the money will find the good ideas. I'm not worried about that. But if we don't have those ideas and we're not sort of creating a funnel, that's the issue. And I also run a digital health accelerator, and I get inbounded by dozens of ideas every day. But I see very, very few public health ideas come through. Oh, see? Great.
That's great. We have another question. Great.
Yeah, thank you very much, and really great panel. So I come from a really small community in Ghana. I'm currently a PhD student here. And back in Ghana some years ago, when we were at the cusp of digital innovation, we saw a lot of young people trying to leverage digital tools to solve problems in health. However, one thing that we kept hearing was that the stakeholders in the public health system were very probably adamant, or they were slow to change, right? So in the face of these terms, slow to change, were bureaucratic, for somebody who wants to innovate leveraging these tools, how easy would it be to make it happen? I'm not very much matured to understand the system here in the States, but I presume it's even probably better off, and a lot of the innovations that we see back in Ghana and other low-resource contexts are developed from here, right, for public health cases. So if we are going to see the adoption of these tools, how and what should we be doing? I think it would be good to have some conversation and your thoughts on that. Thank you.
Thank you.
Maybe I'll just start and say, first of all, thank you for the question. And I actually think we have so much. I've spent 20 years doing work in South Africa and Cote d'Ivoire, and I think we have a lot to learn bidirectionally on the systems in public health and healthcare. One of the things that I think we need to do as we talk about these partnerships is not, I have this new tool, this new shiny object, and now I'm going to partner with the government. It is more like, I have this idea and I want to make it big. I'm going to need to talk to the government now as to what is going to be the regulatory challenges that I'm going to face down the road, so that it can be maximally implemented at the time, because there are a lot of them, and you probably can't anticipate the ones. Part of the reason that I'm like dancing around all these different academic spaces is to try and break down those silos and to foster that collaboration. I can't tell you how many times I was on a Zoom screen where I was the only MD and it was 9 lawyers. And so really we need to, and I'm like, I'm sorry, what language are you speaking? We really do need to understand at the outset, what is it that we want X company to do, X innovation to do, and not only can we build it, but what are going to be the barriers to implement it when we do?
Yeah. Can I put a little asterisk on that? So absolutely, I mean, getting that insight about what is actually needed and getting that sort of that design phase and involving the government is super critical. The only issue is that once you've sort of set that that vision, it is very hard to get government funding or support. So oftentimes what we've done, and I've seen some of my colleagues, we've then built those tools because there was a gap in the market, and we didn't necessarily have those stakeholders on board just yet. But we built it because there was an information gap, there's a data gap. We have several systems that exist like that are now core CDC systems. Vaccines.gov is one example that we run now that existed in a silo. There was Health Map was another tool. Outbreaks Near Me is another crowd. So we've done this without, so we always had insight from our stakeholders, but we haven't waited necessarily for permission or the funding to come through. That can come later if you obviously show the value add. So just a little asterisk.
Can I just add that also, I think you pointed, Rochelle, before that, this is a whole of society approach, meaning that maybe not the government, but how about the corporations? How about the private sector? So I think that we all need to be together in this, the corporate, the partners, the NGOs, and of course the government, and not necessarily think that it's just, this sector, the one who had gonna, buy that solution, but how about the others? There's a co-responsibility, and I have found that for some reason public health have not yet done a great job in really partnering with corporations. We kind of fear corporations for some reason, but I think it's time. It's time to really build those relationships, strong relationships with everyone in our communities and in our society that brings, something to the table.
Our last raised hand.
They had such difficulty getting through to the government because it wasn't in the epidemiology toolbox that our agencies had, the CDC. So I think that, if there was a way that the venture capitalists, the government representatives, private sector, academia could come together and see these, and pitch. People could pitch their ideas, and then there'd be tendrils out to the various funding streams. And foundations are also a critical player. But we need a new model because, again, public health, we're seeing digital innovations and device innovations in clinical medicine and the basic sciences, but not in public health. And that's what this new field is all about, but we need a new model as well. Yeah. So thank you all for your insights.
Great. Thank you so much, Susan. I think we just heard a call to action for those in the room. So thank you for that as a wonderful way to end this esteemed panel. Join me in thanking the panelists for the discussion.
All right. So I think we now have a couple of opportunities that could be written up right now for ARPA-H. That's what I'm hearing. Public Health Incubator. All right. That should be a WIBGI. Great idea. So you guys know the drill now, right? Blue Post-its. We're going to generate WIBGIs based on that conversation. I don't know if we need any more questions. Are there any more questions? Wait, time out. I forgot. So we have quite a few tables. We lost some folks, and we have some tables that are missing some people. So we definitely, we want to go ahead and consolidate tables. Can't hear me? I'll hold it. Want to go ahead and consolidate tables if we can. So if you are a note taker at a table, will you raise your hand? So if you're at a table that doesn't have a note taker, we need you to find a note taker. And we need one note taker at this table right here. Oh, we have one? Oh, okay, he's there. His hand was just down low. We'd like to have at least 6, 7 people per table just to have a more meaningful conversation. All right. Okay, so if you find yourself at a table with no note taker, you're in the wrong place. Do we have any tables without one? Okay. And if there's any note takers that need a break, raise your hand and we'll provide a backup. All right, so we're going to go 15 minutes again, generating WIBGIs around education leadership development. We'll come pick them up. Thank you.